while I was in Rome in 2019, I think I talked about prioritization. I think prioritization is such an important concept, and because of this COVID pandemic, I think the world is becoming more and more aware of the concept of prioritization, because even in high-income countries, we had to face the challenges that low-income countries usually face every day during the time of the pandemic, and we had to be forced into thinking in terms of priorities. What are priority cancer treatments? Which patients should be at a top priority that we should be treating them despite the pandemic, and what sort of treatments can wait, or what sort of treatments are even futile and maybe we don't need them at all. So this thinking in terms of priorities is an important concept, and because of the pandemic, uh, even high income countries are now at least thinking in terms of priorities. During the time of the pandemic, we really did a good job about prioritization of treatment based on which has the highest level of evidence, highest benefit, and highest saving in terms of life years. Uh, but I think we should take it a step further, and we should continue to think about prioritization even after the pandemic has settled down. If we forget all those lessons, then that will be a waste of the experience that we learned from the pandemic. Uh, but having said that, if we continue to look at the cancer drug and the cancer treatment landscape in the United States and Canada, um, and other high income countries, we see that sometimes it feels like maybe we haven't learned those lessons very well. We are still, sometimes I see people advocating for low value drugs, low value treatments, um, and people are still unaware of prioritization of treatments and prioritization of drugs, and people are still unaware of how to appraise the evidence well and how to understand the magnitude of clinical benefit well in terms of the price. I guess one of the important papers that I wrote regarding the pandemic and its consequences on cancer treatment and policy, it was published in JAMA Oncology, in which we ask this exact topic that I just talked about, which is, can we use this experience from the pandemic to identify and eliminate low value practices in oncology? Because during the time of pandemic, we told our patients that, some of the patients, we told them that their treatment was not a high value treatment, so probably it's not worth risking getting COVID infection by coming to the hospital, and it might be better for them to not come to the hospital to get those treatments, because we thought those were low value treatments. Um, During the time of the pandemic, I know from so many of my colleagues that they stopped a lot of what we always thought were futile treatments, or low value treatments. So we wanted to take it a step further, and we wanted to ask in that paper, if we thought it was low value that patients should not come to the clinic to risk getting COVID infection, then probably it's not worth even doing it in normal times. If we think that it was not worth doing in COVID times, we need to ask further, and we need to think, is it worth doing even in normal times? Because in the case of the pandemic, the risk was apparent that the patient might catch COVID-19, which would be a big deal. But even in normal times, if the benefit was so small to begin with, then was it even worth doing it in normal times? And there is always the risk of the patients getting side effects and other complications of the treatment and financial toxicity. So maybe we are downplaying the risk, and maybe we are overestimating the benefit in normal times. And during the time of pandemic, we were forced to acknowledge that, yes, it was actually a low value practice that we had always been doing so far. And if that's the case, I think uh, we should we should ask this question ourselves as clinicians, as patients, and as policymakers. If we said this was not a not an important enough treatment to be delivered during the time of pandemic, was it actually an important enough treatment to be delivered in normal times? And if we ask in that way, I think we'll be able to identify a number of low value practices that are not benefiting the society and might instead be harming the society at large, and we might be able to able to reduce those practices. It is a big problem, and it is one of the areas where I have been working and have been publishing papers, uh, because the fast track drug approval, or in US it is commonly known as the accelerated approval pathway, it's a nice balance between early access to drug and confirmation of benefit, because it allows early approval and patients can use the drug early, with just on the basis of surrogate endpoints. But later, our confirmatory trial has to confirm the clinical benefit. And if that confirmatory trial does not show clinical benefit, then the approval can be withdrawn or revoked. So that's a nice balance. But in reality, what's happening, what we have shown in our papers, is that the first part happens well, early access part happens well, but the second part, the confirmatory trial confirming clinical benefit, does not happen very well. The confirmatory trial sometimes does not even is not even conducted. B, when it is conducted, there is a substantial time lag between approval and confirmatory trial, so that we don't know clinical benefit for a number of years. Third, the confirmatory trial continues to use surrogate endpoints, and only in 1/5 of the cases it uses overall survival endpoint. And fourth, even when the confirmatory trial shows that there is no clinical benefit from the drug, even when the confirmatory trial is negative, the drug continues to remain on the market, and withdrawal or revoking of approval rarely happens. So in theory, fast track approval and withdrawing approval if clinical benefit is not confirmed is a great approach. But in practice, it's not happening as it was intended to happen. So in practice, it's not fulfilling its job, because we are not mandating uh, that confirmatory trials are completed in time. They use clinical benefit as the endpoint, and the approval will be withdrawn if clinical benefit is not confirmed. So this second half of the package is not happening in practice, and that's where the problem is. I think Bhutan has done wonderful in terms of vaccination. It is a great example. It's a neighboring country from Nepal, and it has done really wonderful in terms of controlling the pandemic with such high vaccination rates. But I think Bhutan is an exception. Most of the countries in low-income countries, most of the low-income countries, or most of the countries in the global south, they haven't had access to vaccinations. And I think this pandemic has not leveled the playing field. In fact, it has exacerbated the divide between high-income countries and low-income countries. When in high-income countries, we have the luxury of debating whether or not kids should have vaccinations. In many low-income countries, elderly population, population with severe comorbidities, they are lacking access to vaccines. So, when on one end, let's say in high-income countries, some people are even wrongly questioning the efficacy of vaccines. In low-income countries, people want to get vaccines. People want to be vaccinated. They want to be saved, but they are not having any access to vaccines. Bhutan is an exception, and Bhutan should be commended for being able to achieve such high vaccination rates. But most of the countries, Nepal, and other countries, countries in Africa, they are having so much trouble having access to vaccines, and this is only going to increase the gulf between the health inequity between high-income countries and low-income countries. And because it is a global pandemic, and no country has been able to remain aloof from it, I think this is in fact a good opportunity for all the countries to work together to control the pandemic. It is a pandemic, it's not an epidemic or an endemic. It does not affect only one group of population. So as long as the low-income countries remain vulnerable, the entire world remains vulnerable. So we need to be able to work together to to increase access to vaccines and to help each other when it's needed.